Hi, everyone. Welcome to our presentation on the science and social aspects of multimodal analgesia. Quick introduction, I'm Tony. I'm a general surgeon here in Eureka. I'm very passionate about evidence-based medicine, and one critical aspect of that is evidence-based pain management. So I was asked by your educators and administrators to prepare a presentation on multimodal analgesia, and I'm honored to have a little bit of your time. A side note, you will notice that this talk is very heavy on surgery examples, not just because I'm a surgeon, but surgery is a great testing field for pain management. Many pathologies that require surgery cause pain, like fractures or hernias and infections, and surgery itself is inherently painful. So I talk to thousands of patients per year about their pain and their pain management, and I've seen the evolution of multimodal analgesia firsthand. So to get to it, we'll start with a fairly typical case. We'll go through an overview of the history and science of multimodal analgesia, and we'll take some questions along the way. So let me introduce Bob. Grumpy Bob crashed his motorcycle and has some orthopedic injuries, some rib fractures, and he's post-op day 1 after exploratory laparotomy on admission where an intestinal injury was repaired. He hurts. It hurts to take a deep breath. It hurts to cough. It hurts when he gets out of bed. He's getting around-the-clock Norco and Dilaudid, and all it says his pain is 10 out of 10. So what happens? He's splinting from the rib pain. He's got increasing oxygen requirements. Now he's sleeping most of the day on all the narcotics except for meals. By day 4, he hasn't had a bowel movement. He's increasingly distended, starts having crampy abdominal pain. He's taking increasing Dilaudid for that. Now he's getting extra Dilaudid at night to help sleep. On day 6, he's nauseated. TPN started because he's not tolerating diet. Day 8, he's starting to get enemas. He's had return of bowel function. Only on day 10 is he finally working with PT, tolerating to clear liquids. This is fairly typical stuff. Bob is suffering from the combined side effects of his injuries and surgery, as well as the side effects of his narcotic regimen. And it's a feedback cycle. Their narcotics slow down his bowel function. So he has progressive constipation and secondary pain and nausea. So he gets more narcotics for that. The narcotics are making him itchy and sleepy, and he's getting Benadryl for the itching and spending even more time in bed. And all this time in bed, plus the rib fractures, is causing progressive atelectasis, and his oxygen requirement is persistent. His nausea from narcotics and constipation have made him unable to tolerate a diet, and now he's got a PICC line on TPN. But it doesn't have to be this way. Bob didn't want to be deconditioned on TPN with refractory constipation and nausea a week and a half after his accident. Pain is a predictable part of medical care due to injuries or devices or mobility, and a new model for treating pain has evolved to address patient-centered analgesia, but without the side effects, the dependence, and the functional problems associated with using narcotics as the primary strategy for managing pain. And we can all agree that narcotics, while obviously necessary and appropriate in some circumstances, have a lot of adverse effects. So maybe you already know the history behind the narcotic epidemic in the US, but I'll review briefly. In the late 1800s, opium and morphine were recognized as causing serious addiction and other adverse effects. Heroin was synthesized and marketed in America as a non-addictive substitute, but subsequently was also found to be highly addictive and taken off the market. As late as the 1970s, opioids were used rarely and for acute severe pain. In the 80s, opioids were deemed, quote, safe for broader use based on opinion articles and anecdotal experience with no grounding in evidence or scientific studies. In the 90s, OxyContin, the long-acting version of oxycodone, was extremely heavily marketed to the public and to medical providers alike, with bogus data, a lot of money, and prescriptions skyrocketed for chronic pain and acute pain. As if we didn't learn from heroin, which had also evolved into the most abused and addictive narcotic, OxyContin was marketed as a non-addictive narcotic. In the mid-2000s, the Joint Commission decided to incorporate patient perception of adequate pain control into the quality metrics, feeding even more liberal prescriptions to satisfy patients so we didn't look bad on paper. By 2010, it was clearly an epidemic. There was increasing local and national interest in drug monitoring programs, substance use counseling, Narcan prescriptions, education. CMS changed its HCAHPS questionnaire so that pain management satisfaction was no longer directly questioned. And by 2020, prescriptions remained high. Patients were dependent on prescription narcotics, increasingly turned to illicit sources to sate their addiction. Increased exposure to synthetic opioids like fentanyl, which have very narrow therapeutic windows, caused overdoses to skyrocket. So here are the USA deaths per 100,000 people from the year 2000. You see those numbers going up, and they're very sobering numbers in the US. More people have substance abuse issues than diabetes. Opioid use is more common than tobacco. Americans are twice as likely to die of opioid overdose than they are of a car accident. The USA currently uses 80% of the world's opioids, yet we account for less than 5% of the world population. And history bears out that this epidemic is something that we, the medical providers of the USA, created. So, therefore, we should be aware of the evidence behind pain management so we can be part of the solution. So, what are we talking about again? Multimodal analgesia, also known as narcotic-sparing pain management or opioid-sparing pain management, but note, not necessarily opioid-free pain management, i.e. no opioids, a common misconception, although opioid-free regimens are common and effective for many sources of pain. So you might recognize this. These were classic nursing orders from my surgical training and replicated in some form or fashion before and after in every single inpatient setting I've ever worked with in the US. Anyways, this is the old way. The narcotic if the patient reports severe pain, and the Tylenol if they report mild pain. The new way is multimodal analgesia, with a holistic approach where non-pharmaceutical approaches and analgesics are stacked on top of each other, starting with the safe stuff and adding agents as necessary. So focusing on the medications, which is the primary point of our discussion here, a typical multimodal analgesia plan might be that the patient takes Tylenol first, maybe even around the clock at max dose. If that isn't enough, they take NSAIDs as well. If that isn't enough, we add narcotics for breakthrough. The critical point is that this is in addition, not instead, and always starting with the milder, safer medications first before escalating to the more problematic meds. And while we won't get into the weeds during this talk, there are countless other adjuncts that are built into multimodal analgesia, like topicals and lidocaine and magnesium and neuropathic pain meds and ice packs and hot packs and behavioral therapy, to name just a few.
What do I do when a patient says that Tylenol doesn't work for me?
That's a good question, and that comes up a lot. So I think that we would need to back up a step and touch on what the patient means by work. If the patient has expectations that a single medication will knock out their severe pain, then yes, it won't work. But this is an education issue. Tylenol is not supposed to drop severe pain to mild or no pain. It's part of a group of meds that taken together will work. I think that the data we present here will give you a script that you can use to answer that question well. Or sharing information like your provider wants you to take Tylenol first, or Tylenol is part of your pain management package so that the other medications work even better. Or you could listen to the slide set and choose an idea that works well for you based on this presentation. But thank you for the question. So what obstacles do you foresee? While this is not a new concept, it is relatively new to Humboldt, and there's been a lot of stress as patients and providers consider this change in practice. The major obstacle I see is adjusting expectations, patient expectations, and maybe nursing expectations. So patient expectations are that severe pain needs narcotics. Honestly, nursing expectations are often the same. Most folks in the community worry that medications available over the counter will not be strong enough, but the science is there. Pain for most acute pain and typical surgical procedures can be managed with little to no narcotic. So the major pitfall is not the pain regimen itself, it's managing expectations of the patients and community about what multimodal analgesia is. There is real and reasonable fear about undertreating pain, and expectations from all shareholders in the community have to be addressed if we're going to change the culture.
Dr. Tony, what do we do when a patient is constantly rating their pain as severe? And if it doesn't seem to correlate with what I'm seeing as their nurse and they really appear comfortable?
That is a great question. That is probably the most common question I get from the floor nurses. So this comes up so frequently that I actually already have a few slides on this coming down the line. So let's come back to that question later if those slides don't answer your questions. So I'll start here by presenting a few cases as we go. These are all real examples from the 2 weeks prior to preparing this presentation, with some identifying characteristics changed around to maintain HIPAA compliance. So we'll take our elderly man here with end-stage metastatic pancreatic cancer who comes in for outpatient Porix catheter for recurrent pleural effusion. He's got dyspnea, he's got a large effusion. He's actually even meeting with hospice tomorrow. Currently, his pain is managed with 1 or 2 tablets of Tylenol a day. But he's worried about postoperative pain and asks for a Norco prescription prior to surgery. But I explained to him I'd like to stick to a non-narcotic regimen. Then he asked for Norco after surgery, and we discuss again. After I leave the PACU, he asked his nurse to ask me for Norco after I'd already discussed a non-narcotic pain plan. So the nurse calls me up, asks for an order, at least for him to go home with. He remains sick, hypotensive, fragile, and unwell at baseline. So I understand that everybody's concerned about his pain being undertreated. What would you do? Well, it's clear that he's nervous. I chose to stick with the plan. I went back to the bedside. I treated his anxiety. I reassured him that narcotics are not likely to be necessary to control his operative pain. We'll keep with the previous plan with Tylenol every 6 hours, NSAIDs as needed. And then I called him the next day. The next day, his family reports he had no pain overnight with the standing Tylenol, never even needed ibuprofen. They were satisfied with his pain, and they felt relieved that his pain was controlled, and the family was surprised and happy. Narcotics might makes feel like we're honoring his requests, but would further depress his blood pressure, further lower his oxygen levels, and he's already struggling with those problems, increase his risk of delirium. There's no necessarily reason to pick a more dangerous regimen if you have a regimen that can avoid a narcotic that will likely work. So I get it. Do you feel guilty? Empathy is important in medicine, and the expectations for narcotics drive some provider guilt if they're withheld. Would you feel better if you had just given him 5 of Oxy to go home with, or a few tablets of Norco to go home with? Well, it seems like a lot of patients I see since getting here to Humboldt are getting low dose narcotics like hydrocodone with Norco or Oxy for inpatient pain and discharge. So if the patients are comfortable with that, and if the nurses are comfortable with that level of pain control, would you feel less guilty? Would you feel more comfortable if you knew that a non-narcotic regimen was equivalent? Well, the science corroborates that if pain control is your goal, you will get that without a low dose narcotic like Oxy 5, Norco 5, Tylenol 3. This paper is an example of this, comparing a typical combination of acetaminophen and low-dose ibuprofen with the 3 most common narcotics prescribed for pain. And honestly, I find that the most acute pain resolves quickly, so it's relatively rare for my patients to need more than one agent for a few days anyways. So if you want to feel comfortable with a non-narcotic regimen, this is really, really assuring, especially as the meat and potatoes of narcotic-sparing analgesia is Tylenol and NSAIDs. This paper shows in a randomized blinded clinical trial that if the patients don't know what they're getting, giving them a gram of Tylenol and 400 of ibuprofen is the same, as far as the patient can tell, as 1 tablet of Tylenol 3, 1 tablet of Norco 5, or 1 tablet of Percocet 5. So to address a common inpatient pitfall, patients commonly will state that their pain is 6 to 10 out of 10, triggering nursing escalation of pain meds, either because it's, quote, not well controlled or because of the wording of the analgesia orders. However, the numbers are subjective. Additional questions that are important are what functional ADLs are not possible as limited by pain. Can the patient still get out of bed? Can you walk and cough? Can you use your spirometer? Are you constantly distracted from your ADLs by the pain or not? What objective findings does the patient have that they are having uncontrolled or unacceptable amounts of pain? If those suggest reasonable pain control, do not escalate their pain regimen. A memorable example of this for me is an elderly and very fragile cachectic VA patient that had a perforated duodenum and was critically ill in the ICU for a few days, then spent over a month on med-surg prior to discharge because of all of his TPN and drains and discharge planning. But within 5 days of surgery, his pain was well controlled with Tylenol only as an as-needed med by any objective metric. But he would reliably describe his pain as 10 out of 10 to nursing or to me if any of us asked. Whenever a new nurse would take over his care, I would get a call asking to escalate his regimen as he'd had his Tylenol, but his pain was still 10 out of 10. And then I would go to the bedside and ask him if he was satisfied with the Tylenol, and he'd say yes. And he was comfy appearing with his vitals normal, and he was walking and eating and chatting with his visitors and watching TV. That was just how he chose to rate his pain using a number scale. After he came to his first outpatient visit with me after discharge, he was newly distended and constipated, and I learned the SNF had put him on Norco 4 times a day. I called them, and they said it was because he always said his pain was 10 out of 10. I stopped the Norco, and his constipation went away, and he was just as happy with his pain regimen at the next visit. So education and reinforcement can be critical here, with patients and nursing alike so we're on the same page. One handout I use for my own practice for this, for a lot of clinic patients, is partially reproduced here from one of the pages of the pre-op pain handout. It's a PDF from the American College of Surgeons Safe Pain Control handout. So take the moderate pain box in orange. See, there's no like 6 out of 10 number in there or 8 out of 10 number in there. Instead, they use qualitative statements like, my pain is hard to ignore and is more noticeable even when I rest. Or, my pain interferes with my usual activities. But even at that level, the recommendations are for adjunct therapies and non-opioid medications. They're suggesting a short course of opioids for breakthrough pain only when patients report, I am groaning in pain and I cannot sleep. I am unable to do anything. Nothing else matters. So take another case. A middle-aged woman, BMI 40, with a cantaloupe-sized, painful, progressive peristomal hernia. Surgery is a long surgery. It's difficult. She requires 3 laparoscopic ports and a 23-centimeter mesh. I used dozens of tacks to keep the mesh in place. She's got a 7-centimeter fascial defect that's yarded together under tension and an open incision to close a dead space. She's admitted postoperatively for observation and awaiting return to bowel function. So on the day of surgery, I order my standard regimen of standing Tylenol plus escalating NSAIDs and narcotics only for rescue pain. She complains of severe pain, gets narcotics up front instead of the NSAIDs, and has severe retching and vomiting. That might blow out her hernia repair, so fingers crossed, no issues. Then to treat the retching, she's snowed with Phenergan because the Zofran wasn't working fast enough. So she doesn't walk the day of surgery and she requires high-dose oxygen for likely immobility and obesity-related atelectasis. Next morning, she's doing fine again. Typical soreness, but complains of pain. Nausea is gone. She starts walking, but has progressive distension and her post-op ileus is not yet resolved. In the evening, nursing again starts providing narcotics instead of the Tylenol, missing doses of that, skipping the NSAID orders. Now she's retaining urine, starting to get stray cath. She's even more distended and she's no happier. She's back on oxygen. Post-op 3, I cancel all her narcotics so the acetaminophen and NSAIDs are all that she has available. This forces nursing to stick to my plan. She doesn't have an option anymore. She's still walking, but now she comes off the oxygen. She has return of bowel function. The next day, she's doing well and wants to go home. She asks for a Norco or an Oxy prescription. I ask why. As she's doing so well right now and seems satisfied with her pain, she says, just in case, but I tell her no. When I see her in the afternoon before discharge, she says that she told her son that she won't get narcotics and he's very happy. I'm surprised and I ask why, and she admits that she has a lifelong of addictions and she's worried, and he is worried about her getting hooked again. She notes that her pain is fine now, not bothering her, and she's less distended. The narcotics she was getting post-op directly contributed to her ileus and constipation and urinary retention, which caused the distension, which was her primary reported source of pain and likely contributed to all of these other issues. So in an attempt to be kind to this fragile patient with severe postoperative pain, we unwittingly prolonged her pain and delayed her recovery and discharge. She sheepishly told me before discharge that she wasn't really having any pain anymore as long as the standing Tylenol was going with the lidocaine patches, and she's now grateful not to be on narcs at home as it would have been too tempting to her. I would guess I do about 150 hernia repairs a year, and yet I only give patient narcotics for post-op pain maybe once every 20 cases is my guess. And they're doing fine. They go home, they walk, they eat, they get better. They're a satisfied group of patients. My reviews are great. They come back to me when they need other procedures in the future, and this is borne out in the literature. This large matched comparison for large open hernia surgeries, like the previous case, showed equivalent analgesia with opioid and opioid-free pain regimens, with a tendency towards shorter admissions and less complications when you avoid narcotics. And there's plenty of literature in other realms where there's predictable pain, i.e. surgery, reinforcing the efficacy and often superiority of a narcotic-free analgesic regimen. So here's a trial in carpal tunnel release surgery where patients have a cut in their hand, obviously a very sensitive area where historically opioids were prescribed. Patients were randomized to either a Norco 5 regimen or an opioid-free regimen with Tylenol and naproxen. Pain scores were lower in the opioid-free group at the first 5 days and the same at 2 weeks. Satisfaction with pain management and function after surgery were the same. So here's another one. 188 patients randomized to oxycodone versus ibuprofen versus acetaminophen. Pain satisfaction, the same across groups. Post-op pain scores were highest in the patients who actually got narcotics, and almost all of the adverse effects were in the narcotic group. Want to keep going? Here's one, an effective opioid-free analgesia for laparoscopic colectomy. A trial showing better analgesia without narcotics for rotator cuff surgery, which is classically extremely painful. Opioid-free analgesia for acute neck and back pain. More carpal tunnel literature, better without opioids. Labral surgery of the shoulder, equivalent without narcotics. Rib fractures can get by with less or no narcotics for the multimodal regimen. Same with knee replacement. Tylenol and ibuprofen combination works better than narcotics for wisdom tooth extraction, and it just keeps going. So let's take another case. An elective hernia, it's another big one. She's got a 10-inch mesh inside of her, 2 full tackers used to secure it. She's in recovery, and I see her in short stay. She looks comfortable, looks well. So I think that we'll probably get by with my usual regimen. So I stick with my usual plan, usual instructions, usual no narcotic regimen. On post-op day 1, she calls the office. She's angry. She's angry about her pain management. She says she needs something stronger. She drops the F-bomb when describing how she anticipates things will go without narcotics. But I asked her what she's taking. She's used Tylenol once in surgery and ice packs, nothing else. Says that she has no pain in bed with ice packs, but when she's walking, it's very uncomfortable. By her report, her pain management is reasonable, and she isn't even taking the NSAID yet. I insist she try my regimen and call me back if her pain is intolerable.
These patients can ask a question.
Of course.
What do we do when the patients are refusing to take their non-narcotic?
That's a good question, and that definitely comes up a lot on the floor. So first off, obviously, we don't force patients to do anything, but we have to know that most psychiatrically normal patients can be educated so that they understand why we are presenting, offering, or insisting on a non-narcotic option first, and then they accept it. It's an education thing. And this is by far the most common thing that comes up when I get called by nursing saying a patient is refusing acetaminophen or refusing naproxen or whatever. When I actually go and chat to the patient, do a little education, they're amenable to giving it a try. So this lady was an example of that. At the 3-week follow-up when I see her in the clinic, I asked her how her pain regimen was after she was initially so upset. And she said, in retrospect, it was fine. It just hurt when she was getting out of bed, and she did take more CBD gummies than usual for the first few days post-op with the naproxen. She admitted she was very embarrassed to be so angry on post-op day 1, but she was grateful to avoid the severe constipation she'd had with one of her previous surgeries on narcotics. So those are some outpatients, because outpatient surgery is most of the surgery that I do. So that is most of my pain management discussion. But you guys are inpatient providers. Maybe you have an inpatient that says they will not be well controlled without narcotics, or maybe they say they need something for a breakthrough and they've already maxed out their NSAID. Someone may tell you that you have to increase their pain regimen, or you may feel personally compelled out of concern about legal risk, even though you feel that their pain is appropriately controlled. So I've spoken to nursing administrators in the CNO about this when it came up a couple years ago. So to be clear, there is no mandate for a nurse to escalate up the pain regimen because a patient requests it. You are a clinician and you make a clinical interpretation. If the patient is comfortable appearing, undistracted by pain, functional enough in their ADLs, normal vital signs, etc., you can make an objective statement saying there is no reason nor mandate to give them a stronger med with higher risks. This applies to nurses and physicians alike. You can tell them that they'll have to wait for their next available dose, or that they can speak to the prescriber about it tomorrow, etc. Don't dismiss them, but don't enable them. This is a slide from Providence's yearly education PowerPoint. It says that you, as the nurse, have to assess their pain and treat their pain, which you're doing, but nothing is said that you have to satisfy the patient or meet a certain numerical target. It is clearly stated, and I quote, "The treatment modality selected shall be appropriate for the patient's needs, and treatment shall be consistent with the patient's clinical presentation and objective findings." Remember that a patient telling you that their pain is out of control is a subjective finding. It states further, if a decision is made not to treat a patient's pain, then the clinical justification for that decision should be documented in the patient's medical record. So that's what I do when it becomes a drama, right? If the patient's, demanding this and demanding that, and I really strongly feel that's not the right thing to do, I do document in the medical record why I'm not escalating the regimen to their satisfaction. And you can do that too. But arguably, you are treating their pain. You're probably just not treating it to their satisfaction or to their requests. So whether additional documentation is even helpful is questionable, because again, it stated, if a decision is made not to treat a patient's pain, then the clinical justification for that decision should be documented. You are treating their pain. You're just not satisfying them. And I'm not saying that all of my inpatients and outpatients are satisfied with their pain regimen. There's definitely some outliers, and happily they're rare, otherwise my life would suck. But it seems like the vast majority are the kind of people that you just can't satisfy even with narcotics. So a recent paper in one of the big important European journals published a huge meta-analysis that confirms my anecdotal experience. They looked at minor and major surgeries, and their conclusion after crunching all of this data for patients who are sent home with and without narcotics is that opioid prescribing at surgical discharge does not reduce pain intensity, which correlates with patient satisfaction, but does increase adverse effects. Or you could just take my anecdotal experience. I've been busy since day one of surgical residency training. And in that time, I will have conversations about pain by estimate 2,000 times a year in some way or another. So throughout med school and in the beginning of my surgery training, we prescribed liberal narcotics. It was the expectation from our attending surgeons and our patients. But as the weight of the opioid epidemic set in and California started regulating narcotics, we prescribed less and less as surgical training continued. And I was seeing a lot of downsides from narcotics and started learning about alternative pathways and multimodal analgesia. I started recommending Tylenol and ibuprofen like I do now, and sequentially started decreasing the number and doses of narcotics I would send patients home with for breakthrough for a typical surgery like a lap chole. By the time I was year 3 as an attending, practicing independently, I was no longer prescribing any narcotics at all for an outpatient gallbladder surgery or an outpatient typical hernia repair. And I did that for years and years. And until about a year ago, I've been getting all of my own calls, seeing all of my own post-op patients. And what I learned is that I got the same number of calls from grumpy patients who were dissatisfied with their pain regimen or said that their pain was out of control or they were stuck in bed and couldn't move, despite sequentially lowering the narcotic availability from 45 tabs of Percocet 5 with refills to no narcotics at all. But what did change is the constant calls I used to get about vomiting and dizziness and nausea and terrible constipation have almost completely disappeared.
What about patients that have a chronic pain diagnosis or a substance use disorder? How does that affect the multimodal analgesia plan?
That is a good question, and that's a tricky question to answer simply. Um, it It depends completely on the clinical situation. It depends completely on the chronic issue, the doses, the degree, and the type of pain. But first off, to rewind a little bit, I always make sure the patient is not missing home meds or withdrawing from chronic meds. I never drop patients home doses of gabapentin or pregabalin or duloxetine or SSRIs or methadone or Suboxone acutely when I'm managing their new surgery pain or their new trauma pain, as all of those have their own withdrawal symptoms, own withdrawal syndromes that can make them hypersensitive to pain or anxious or cause other issues that complicate their management. That said, I also don't increase those meds either unless there's an unusual or clear reason to. That is because most acute pain can be managed with a non-narcotic regimen. And happily, Tylenol or ibuprofen or naproxen or whatever work just as well for a patient on Suboxone as one who's opioid naive. Patients who are on chronic narcotics develop tolerance rapidly and no longer get the same analgesic effect from a given narcotic dose. But that tolerization does not apply to NSAIDs and acetaminophen, so you can still manage severe pain with those meds. Now, for those patients that do take methadone or Suboxone and have a high tolerance, when you do need narcotics as well for breakthrough, which some patients do, just remember that much higher doses of narcotics will typically be needed for rescue pain because of the chronic tolerance. So maybe you're thinking, that's them. We don't have a narcotic problem. You know, we've been using oxy and morphine for decades. Norco works just fine. It's working out, so why bother? All this drama about the opioid epidemic, that's just not us in Humboldt. So let's bring that home. This is the most recent compiled data accessed in August for Humboldt County. So this is opioid-related deaths. This is opioid-related overdose visits. So you should know that opioid-related deaths are actually down over the last year and a half in Humboldt County, which is great. I'm not arguing that's not a great thing, but a lot of people feel that's actually just due to new legislation mandating Narcan prescriptions and the fact that Narcan is now available over the counter. But the overdose rates, which is what this graph is, continues to rise. And this is Humboldt County, homegrown. So maybe you're thinking, well, that's just all the street drugs. But it isn't. This is the last 3 years of opioid overdose visits that made it to the ED related to prescription opioids only, and that is rising too. People are overdosing on prescribed oxy, prescribed Norco, prescribed tramadol, etc. Deaths may be down year to year, but just because we've become more effective at rescuing overdoses from dying doesn't mean that we're ready to declare victory. And I see this all the time in my practice. We have a deep well of patients in this community with a history of narcotic problems or active narcotic use. It's just a sign of how important this topic is. Take this case for a patient I saw in clinic last week. 35-year-old guy with a history of illicit opioid and meth use. Now he's on Suboxone, clean from meth. He's got bilateral inguinal hernias, saw me in clinic. I set him up for surgery about a month ago. He said that his previous recovery from a laparoscopic umbilical hernia repair was awful, with severe pain for weeks, and he wants to be sure his pain will be better controlled. I share my standard regimen. I give him the pain handout I showed you clips from. He's got reservations, but initially says he'll try it. A week before surgery, he calls the office a few days prior saying he's had a change of heart. He's requesting a prescription for narcotics as he's thought about it and feels that his pain will not be controlled with Tylenol ibuprofen alone, as it was not even controlled with Norco last time. I tell him we'll discuss it again on the day of surgery, and on that day I emphasize that this should manage his pain, and if he doesn't, he can call me the day afterwards and discuss. He's pretty upset about it, but he does want to proceed with the surgery, and he already had his date, so we proceed. He doesn't call post-op, and I'm sitting there chewing on my fingernails waiting for that one-star review to pop up. But at the follow-up visit at 3 weeks, he says he's recovering well. He wonders when he can go back to heavy lifting. I ask timidly whether he was satisfied with his pain regimen, and he was. I ask, as he'd had such concerns about his pain regimen and how angry he was, how it worked out, and he says that in retrospect it was fine, and he was glad he did it without narcotics, as last time he'd had terrible constipation and then withdrawal after he came off them last time, and this time it wasn't a non-issue. He would do it again the same way next time. So it's not just patients making bad decisions about how to use their prescribed narcotics. Available narcotics in the community lead to accidental overdoses and deaths in patients with no tolerance when a friend is helping them out or a child gets access. And in the last 2 decades of data for pediatric poisoning fatalities in the US, this paper shows that 47% of fatalities in kids were related to accidental opioid ingestion, not something that had been prescribed to these children. The percentage of deaths by opioid is trending up over time. Over 50% of all peds poisoning deaths were opioid by the end of the study data range. Family and kids do worse when there are opioids around, and pets are also common accidental overdose victims. Anyways, maybe you agree that there are unacceptable side effects of opioids, but you feel uncomfortable not offering patients in pain a medication that you think is the normal way to treat them. But what we're doing here isn't actually normal. Maybe we are the ones that's deviating from what's normal. So we can look at some data. This is a paper in the Annals of Surgery from a couple of years ago looking at discharge medications after appendectomy, cholecystectomy, and hernia in 7 representative countries around the world, including the US, including a spectrum of developing countries to middle-income countries to countries with advanced healthcare systems that are beating us easily with respect to outcomes and quality of care. So what do you guys think the rest of the world is doing? What percentage of patients in the USA versus other countries were sent home with narcotics after these typical surgeries? So the findings was that this sample of global prescriptions showed that their patients, the non-US patients, were going home with narcotics 5% of the time, compared to our US patients going home with narcotics for the same surgeries 91% of the time. Some countries and locations are at 0%, and they're still doing surgery and patients are still getting better. Obviously, we're all human. We all have the same pain receptors. We've got the same brain, but different expectations. And in those countries, a non-narcotic regimen is considered appropriate, acceptable, and satisfactory, and those patients go about their life without narcotics. This review concluded that US physicians prescribe alarmingly high amounts of opioid medications, and further efforts should focus on limiting opioid prescribing and emphasize non-opioid alternatives in the US. So you might be asking, where do you go from here? To bring it home, just remember that Humboldt is in the grips of an opioid epidemic, and we're overusing dangerous medications. Treating pain is a critical part of good medicine and good nursing, and to be the best advocate for your patient does not necessarily mean to provide narcotics. It means to assess and treat pain with a multimodal regimen that optimizes good outcomes and minimizes side effects and dependence. So first, educate. You do that best. Pain is normal. The absence of pain is not the goal. The goal is healing and function and good patient outcomes. I never forget how important nursing is as part of the team. You guys are the people actually doing the patient care. You're the person at the bedside night and day. You can be a force for good and an agent of change. But with your great power comes great responsibility. You have the ability to ruin your patient satisfaction and undermine the trust in their providers if you reinforce inappropriate expectations, and we appreciate your professionalism and teamwork when taking care of our inpatients. Let's take a look at another case. A young woman recovering from an umbilical hernia repair. She calls in, she is unsatisfied. 2 days after surgery, she's describing severe pain, 10 out of 10, and is taking all of the allowed Tylenol, NSAIDs, and lidocaine patches as suggested. But she reports that she's taking the dogs for walks around the neighborhood. She finds the pain distracting but not limiting, and it hurts worse when she picks up a backpack or gets out of bed. Maybe if I had educated better, if I had explained better before surgery that her reported pain was normal after surgery and she's really at an ideal goal, she might have been satisfied beforehand. And we know both from our personal experience and the trial data that adding narcotics will still be unlikely to result in satisfactory pain management per her preconceived ideas of no pain or little pain shortly after surgery, but subject her to all of those downsides. So at the bedside, in the inpatient setting, think holistically and assess for the sources of pain. If you just ask for a number, you don't get much data. Is it the surgical site pain? Is it fracture site pain? Or is it something else? A very common complaint I get from patients is that the time in bed and the hospital bed is causing low back pain, and that is actually their chief complaint, not actually the surgical site pain. So get up in a chair, get them moving, or they're having waves of colicky abdominal pain related to resolving ileus or constipation. Narcotics only makes those problems worse. And
What
sometimes
about patients? Sorry, I have a question. What about patients who need immediate pain control and Tylenol and ibuprofen aren't going to work fast enough?
So that's a good question. So, I mean, some people really do need pain, aggressive pain management and fast. So I don't use oral Tylenol for trauma patients who come in with a bunch of broken bones. But like everyone else, I get some fentanyl going until we're out of like the crisis level pain and then switch to a multimodal analgesic regimen. It's true that oral Tylenol and oral NSAIDs take 15 minutes, 30 minutes to reach maximal effect. And I admit that few patients are in such urgent need of rapid analgesia that the time to peak effect matters. But for those that it does, there still are parenteral options for Tylenol and ketorolac that hit quickly. There's IV Tylenol. It's like $8 a bottle instead of 5 cents for a pill. There's Toradol. There's some other stuff around that I don't think we have in our hospital. And you can ask your provider for that option if you find that a patient truly needs something because PT just showed up early and can't wait to come back for half an hour later, or they had a sudden change in condition. Generally, I do prefer oral formulations because they're cheaper for good financial stewardship and given the overall efficacy is the same. But there are fast-acting, multimodal, non-narcotic options. And sometimes, sometimes you do just need a shot of fentanyl or Dilaudid, but something that isn't the only solution. And sometimes patients are requesting narcotics for the wrong reasons as well. Just coming back to the slideshow, is it even pain at all? Or is it anxiety? Is it insomnia? A lot of patients have quickly recognized that the adverse effects of their narcotic regimen are helping them with their anxiety because narcotics are sedating, or insomnia because narcotics are sedating. We have better ways to treat anxiety and insomnia than using the side effects of an addictive substance. So pain management is a holistic evaluation and a treatment plan. Who better to assess and treat your patient than nursing, who spends so much time with the patients? There are so many things other than meds to treat pain effectively and contribute to a patient's sense of well-being, being listened to, and satisfaction. Remember that there is no mandate to escalate the pain regimen with an increasingly dangerous regimen of NSAIDs, neuropathic pain meds, and narcotics just because the patient demands it or states that their pain is so severe or 11 out of 10. And as an agent of change, you can talk to your ordering provider, advocate for the patient. Is your patient having narcotic side effects? Would they be a candidate for a multimodal narcotic-sparing regimen? You can advocate for a typical regimen, Acetaminophen is the core synergistic analgesic in almost every multimodal analgesic pathway, with safe adjuncts like ice packs, hot packs, sit fast, elevation, managing many mild to moderate pain sources in the inpatient outpatient setting. And then for moderate or severe pain, adding NSAIDs, muscle relaxants, nerve pain meds, topicals, and reserve narcotics only as the last additional med. As for most patients, they have far more risk than benefit and should be used in the lowest effective doses only. There's also plenty of self-education or patient education materials available if you want to access them. I'll put a few up here with some QRs if you want to access them directly or print them for patients that you care for. This is one from the American College of Surgeons Safe Pain Management handout that was featured in this talk. It's a nicely produced PDF designed for patients that touches on pre-op and post-op pain management, sets expectations consistent with this presentation. The Society of Hospital Medicine has a 25-page overview of multimodal analgesia, including a review of medications, managing expectations, de-escalation of narcotics, and transition to outpatient settings. The ACS has an evidence-based medicine regimen specifically for trauma patients with a guideline update just a couple years ago. And take these excerpts from this guideline. Administer acetaminophen and ibuprofen around the clock. Pain is normal after trauma and surgery, and that pain may increase as their mobility increases. Counsel patients that the goal of pain management is not eradication of all pain. Opioid.org is a post-op pain management resource with a library of pre-procedure, intra-procedure, and post-op resources and guidelines for patients and provider education. While I understand that there aren't a lot of surgeons in the audience here, surgery is a nice proxy for any event that causes acute pain, and I would argue that most of the perioperative multimodal analgesia regimens are generalizable to most sources of inpatient and outpatient pain. And I do use these principles for my own non-surgical patients. In conclusion, understand that a primarily narcotic-based pain regimen is no longer standard of care in American medicine, and this is reinforced in all modern evidence-based medical and surgical literature, nursing guidelines, hospital-based medicine, and outpatient medicine guidelines, except for chronic severe cancer-related pain and hospice medicine. Rather, a multimodal analgesic regimen that focuses on the safer adjuncts and medications with less patient and community adverse effects is the new standard of care and works well for patients. So thank you for taking the time to listen in today, and feel free to reach out to me with questions. You can track me down in the hallway or email me. My email address is here. I'd be happy to continue the conversation and learn from your experience as well. And I'll take any other questions if you had any.
There is another question from some of the nurses in the hospital. They said, I get that narcotics might not be necessary all the time, but what about just giving a few tablets of Norco just as a backup?
That's a good question. So this is a typical question in the post-discharge nursing. So patients, done in the hospital, they've been doing fine. Now they're going home and the patient's can be doing their own pain regimen, or they're going home from outpatient surgery. And it comes back to the guilt thing and the what's normal thing. So I understand the temptation is to just give them a little bit as a backup. It reduces the need for education. It satisfies them. It gets them out the door. But there's a lot of reasons not to prescribe a Schedule II narcotic if you don't think it'll be needed. First, studies have shown over and over that patients are ending up with leftover narcotics at home after prescriptions, even with short course narcotic prescriptions. And if they're using a regimen like I'm advocating now, they shouldn't need it. So now they have loose opioids that the patient's going to have for a rainy day, but it was prescribed for the acute surgical pain, not for a rainy day. How do we know they'll use it appropriately? A patient choosing to use their oxy for a migraine a month later, or give it to their buddy who has terrible muscle strain, is the same as self-prescribing narcotics or getting oxy off the street for use as needed. It's not the right thing to do. It shouldn't be needed, and it kicks the can down the road for culture change and adjusting expectations. You just have to trust that this works, because it works in my practice and it works in the studies. And when the patient is outpatient, it's the physician's problems, not yours. But thank you for the question.
And one other question, what about people with liver and kidney failure?
This is a great question, and this comes up a lot. And the misgivings about Tylenol and NSAIDs are largely based on lack of knowledge. It's true that some patients have relative or sometimes absolute contraindications. to NSAID use or Tylenol, but they're very unusual. So for NSAIDs, for example, dosed appropriately and choosing the left nephrotoxic doses and left nephrotoxic versions will allow a provider to offer NSAIDs to most patients, even patients with acute and chronic renal failure. Even dialysis patients can have NSAIDs, and some literature supports ibuprofen as the safest choice of the common NSAIDs available. Now, that's a complicated discussion, but don't feel that NSAIDs are strictly contraindicated in renal failure or patients who have chronic renal failure or even end-stage renal failure. Similar conversation comes up with blood thinners. Patients on blood thinners are often warned about NSAIDs because they can cause gastritis or ulcers with secondary bleeding, or increase the cumulative blood thinner effect because NSAIDs do have a very small antiplatelet effect. But again, dosed appropriately and for short courses for acute pain, with or without an antacid, or perhaps switching to celecoxib, which is a little bit less toxic to the stomach lining, they can still be used safely in most patients. And then Tylenol is completely overstated as dangerous in patients with liver failure. In fact, the available science supports acetaminophen as the safest analgesic for cirrhotic patients or other patients with end-stage liver failure. There are very few exceptions to this, and they're typically exceptions that we don't see here in this community. Patients who are actively drinking alcohol and cirrhotic, we typically say Tylenol is contraindicated, partly because the liver struggles to metabolize it when they're actively intoxicated with alcohol and have very poor, liver function, but possibly it's just contributed to by the fact that we just don't trust them to take it appropriately and in appropriate doses if they're drinking alcohol. The other patient population where Tylenol is considered contraindicated are patients in fulminant hepatic failure, but those patients don't live here. They get transferred out. We are not talking about profoundly jaundiced patients with cirrhosis and liver failure. We're talking about fulminant hepatic failure. The normal cirrhotics that we keep here in the hospital, they should get Tylenol. That is what they do in the tertiary care setting. Like when I was doing my liver transplant rotation, I spent an entire month in the ICU, and all of those patients had liver failure. They were still getting Tylenol as first line as prescribed by the liver doctors. So it's still not contraindicated, although we dose it down a little bit. So for the cirrhotic population that we recommend Tylenol for, typically we dose 3 grams daily as the max dose instead of the 4 grams dose that we typically recommend for people who don't have liver failure. So that would be 650 milligrams every 6 hours instead of 1,000 milligrams every 6 hours. And if you're really nervous or the patient has really profound hepatic dysfunction, some providers go down to 2 grams daily max dose. But again, this is only for very advanced presentations that we're unlikely to see a lot of in this community. So thank you for those questions. Any other questions?
I think that's it. Thank you for this excellent presentation.
Well, thank you for your attention, and hope to hear some more questions from you by email or in the hallways. Thank you again. Have a good night.